Hi, this is Judy Colditz. I'm responding to a case submitted by Drew Reynolds to the ASHT Discussion Group, and the best response I thought was video. Drew described a client who was 8 weeks status post-close reduction with percutaneous pinning of her small finger proximal phalanx. She had no complication with healing, and reduction was anatomical per the physician. She has normal passive range of motion of the MP, PIP, and DIP in both flexion and extension, but she has poor tendon glide of the FDS and FDP with PIP flexion to 50 and DIP flexion to 50 actively. When attempting to make a fist, she also has paradoxical extension. Drew wondered if she has a lumbrical plus finger potentially from scar adhesions. Let's look at some of the images he provided. First, we're looking at full passive flexion, which we can see is relatively easy, although the MP is not fully flexed here, but we see that later. Full passive IP flexion is also very easy with MP hyperextension. But when we move into active motion in a video, we see that the patient flexes the MP joint and the IP joints do not flex adequately. Look carefully. The MP joint flexes, and as she attempts flexion, there's a slight paradoxical extension of both the DIP and PIP. Look again. Watch carefully. There it is. Now, Drew sent a second video with the same hyperflexion noted, but it appears in this video that the patient's not pulling quite so hard, and I cannot see any paradoxical extension. Can you? She comes down, but she lacks flexion. I grabbed a couple of still images from each video, and if you look at the lower image with the MP joint at 110 degrees, you'll notice that at 110 degrees, the PIP joint and DIP joint are not as flexed as they are above when the MP is only at 104. This demonstrates that the greater MP flexion, I think, is putting tension on the dorsal apparatus and is tethering the patient's ability to actively flex. Although it appears to be paradoxical extension, I really think it's the tenodesis effect created by this hyperflexion of the MP joint. This does occur when there's adherence or tightness of the dorsal apparatus. Because Drew sent us this video where he's holding the MP joint in flexion and the patient is actively flexing, we see no paradoxical motion here because the MP joint is already maximally flexed, and we see a greater limitation of motion. Take note how the other fingers are not fully flexing. We'll talk about that in a minute. Drew also showed us that there is active DIP flexion, but limited. But then, after he shows us this DIP flexion, he moves proximally, and we see that there is also limitation of the PIP joint. That excursion that is available is now having to be shared across two joints, and what that means is the DIP doesn't move as well as it did when the PIP was blocked out and was not allowed to move. This posture of blocking the MP joint is driving motion across the IP joints. So my conclusion in looking at this case that Drew presented is that true paradoxical extension is not present, but it's limited because of dorsal adherence. The treatment would be to block the wrist, CMC, and MP joints and drive all of the active motion to the interphalangeal joints for both flexion and extension, just as Drew is doing here in this video. You can see the patient is getting the motion needed. Now, to be most effective, I think the other MP joints of the ring and long finger need to be blocked. So I would advocate the Sims technique, which I've advocated a number of times. You can see that here in this patient who has progressed to a removable cast, that's not happening in the beginning, that the MP is blocked from hyperextension and full IP flexion is allowed without MP flexion. A sustained period in a cast where no other motion can occur can really improve range of motion and excursion of the dorsal apparatus as well as the flexor tendons. In my opinion, this is the ideal treatment for this patient. I hope this information is helpful. And if you want more information about interosseous and lumbrical muscle tightness, you can go to handlab.com, free resources, choose clinical pearls, and look at number 19 through 22. For more information about the SIMS technique, you can also go to the Rehab of the Handbook, last edition. I hope this information was helpful to you and that it clarified a very interesting point. Thank you, Drew, for submitting this and allowing me to respond.